It's saying that it's disabled for participant screen.
Oh, here. Sorry, I know. See if that works now.
Yeah. Can you all see that?
We can.
Well, what I was going to do today, and this was sort of meant to be a foundation for some of my future talks on maybe different types of medication and different pediatric disorders, but I was asked several years ago to talk about kind of philosophies about prescribing psychotropics for pediatric patients. And so I sort of put together this basic sort of foundational principles about pediatric psychotropic providing kind of loosely. And it's become a really helpful way for me to think about how to approach using medication in kids. And so I hope you enjoy it. Please ask me lots of questions. Because as I said, this is sort of going to be the backbone for kind of future talks that I do on specific types of medicines with kids. So we're going to just talk about some basic principles and kind of language that we use in research and different treatments for kids. So one of the first sort of basic principle is remembering that kids are not little adults. I think most of us that work with patients sort of know that, but it's still easy to forget. This could be sort of the importance of recognizing what the developmental role in pathology is. You know, there's kids are supposed to be hyperactive at certain ages. It has value, and sort of recognizing what the difference sometimes from normal anxiety is versus what is developmental for a kid. And so really appreciating sort of that developmental framework of the symptomatology really matters. It's also really important to remember that we have a lot of limited evidence sometimes for adult medications, and adult medications that we might think for kids don't work the same way in kids. And a lot of this is related to metabolism. Kids really don't develop adult metabolism until they're about 15 years of age. And so they don't handle medications the same way. And sometimes they hyper metabolize things and may need higher doses of things than adults. But a lot of those pathways, especially with psychotropics, are not well developed. Things like the serotonin pathways really take until about the mid-20s to fully develop. And so little kids may not handle some of the pharmacokinetic loads of some of the medicines well, or more prone to side effects. And so that's always kind of important to remember. We talk about this a lot in ECHO, but did the child get a complete evaluation? Is the diagnosis right? This is so important. You know, kids, especially those under 10, don't really walk in and say, you know, I'm depressed or I'm anxious. They present with a whole host of other symptoms, and frankly, sometimes the symptom is a behavior, and we just get a whole list of behaviors. We're so much better at looking at kind of externalizing things with kids, those outward signs, that we sometimes miss some of the internal things and feelings that might be driving the behavior. And some kids can't communicate what those internal feelings may be. And so sometimes when it's not working or not looking or moving the way we think it is, we have to really go back and make sure that we didn't miss something, or the diagnosis is right. And sometimes we just have to admit the diagnosis was wrong, and we have to go back and get more information. This is, I think, really important with things like ADHD. You know, I see a lot of kids that it gets missed, and people just thought that they were distracted, or they forget that there may be comorbidities. It may be that both diagnoses are right, but lots of times the diagnosis kids come with aren't accurate, or something's changed. And I think it's important sometimes to rethink that. And so I want to make sure that we go back and we see when things aren't working? Did we interview the child separately? Did we get collateral from teachers and schools? Was the parent maybe not telling something because they didn't want to say it in front of the kid? Do we need to give the parent more time to discuss? Are there social things going on where, you know, maybe we need input from multiple caregivers or the school? Sometimes those complete evaluations involve a lot of parts and take a lot of time. Most of the time, I think when I explain that to folks, they already are kind of, you know, they're already frustrated or had some challenges. People are pretty open, and I usually tell people, you know, I like to have about 3 times meeting you and going through the information to really make sure I'm completely getting all the pieces of it. I may not have all the answers today when I meet you the first time, and most people, if you explain that, are pretty open to that. But I think that's important to always think about. I guess it's also important too. I get a lot of people that have self-diagnosed on Google and kind of come presenting their versions of things very well intended, but they may have not considered other things too. The third sort of basic principle is sort of making sure that we've kind of explored non-medication options that have been tried or offered. You know, I think in pediatrics, there can be a whole range of different presentations from the caregiver's part. I have some families that are really med-focused and only want medication options. I have some families that are really only interested in psychotherapy and don't want medications. But a lot of times I have a lot of kids presenting with a lot of med failure trials, especially for things like behaviors, and it really hasn't been really explored the other options either at home or school that could be helpful. A real common one that happens is I get kids that get kicked out of school a lot or sent home from school, and they don't appear to have ADHD or other things that they can't control, but really turns out that the behavior is reinforcing itself. They didn't want to be at school, and so every time they acted out at school, they got sent home, and that's where they wanted to be. And so again, there's not a medication in the world that's gonna help that if we don't really address some of the therapeutic and systemic issues that need looked at. So I think sometimes it's important to kind of back off and say, well, what other things have you tried that haven't been medicine related? And then sometimes the things that they've tried haven't always been the right way. If you've ever, if someone ever tells you they've tried time out, I've really learned over the years, well, tell me how you do time out. I did this last week, and a 4-year-old was put in timeout for 30 minutes and quickly realized that's why timeout wasn't working, because it was just way too long. So I think it's always important to try to get more details about those options too. You know, I feel really obligated, and I think parents really appreciated this. You know, if I'm going to write a medication for a patient, I really want to make sure that medication really can help. I think it's really important to give honest information about that, because sometimes it really can't, and sometimes that's part of my discussion with people. I don't have a medication for this. There are certainly lots of things that can help, but I don't have something for that. And again, they sometimes really appreciate it. Sometimes you have to talk them through what those alternatives are. This is a perfect example of that. You know, PTSD and trauma. If you are scared, if your child is scared and terrified and fearing for their lives, I don't have a medicine that's going to make them feel safe. And it's really important to talk about, although I may have medicine that helps them sleep or relax, I don't have anything that will help them feel safe. This is really important to think about those non-medication options. And medicines for PTSD in kids do not carry much evidence at all. So we really have to highlight when medicine isn't the right consideration. These are really important things I want to make sure we define. This, I think sometimes this can be really confusing for parents and clinicians too, but we have sort of two approaches to how we approach medicine. There's of course the diagnosis approach that this person meets some DSM-5 criteria for medications and such as ADHD, and we have really clear treatment plans and things that treat that. But sometimes people present with very vague symptoms. You all probably kind of have better terms for this than I do, but you know, I have lots of parents that they're just moody, they're just irritable, they just can't sleep, and a whole host of really vague symptoms that are really functionally impairing. I think sleep is a great example. Sleep may really be impaired, and it disrupts the entire house, and the next day is terrible when the parents don't sleep and everyone's on edge. But it's really hard to get them to fit into a classic diagnosis or find a medical cause for their sleep. And so as you think about medicine management, you might be treating a diagnosis, but you might just be targeting a symptom. Aggression is another example. If I have a child that's beating a caregiver or self-injuring, that aggression is severe and problematic. It may respond to medicine, but it may not fit as cleanly under the right diagnosis, because there can be lots of different things. So in an ideal world, it's better to prescribe under a diagnosis because you're going to get more evidence base. But when that symptom is really impairing, you might be treating the symptom first and then searching for the diagnosis later. I use aggression as a good example of that. I have had some kids that are just so aggressive you can't even get close enough to them to do an exam or to get out the real information. And sometimes we use medicine first just to calm it down so we can get in and find out the rest. Lots of times when it's aggression, I find out down the road it's later trauma or it's later anxiety. But that aggression was so impairing that we might have had to start there before the diagnosis was clear. So again, it's kind of important when you think about that. If you're using a symptom-based approach, it's really important too that if your medicine choices aren't improving the symptom, that you rapidly keep going back and reassessing that, because it's a lot less certainty about the outcome. Another terminology that's I think really confusing is this idea of if a medication is FDA approved or we call it off-label. Those can be really confusing terms and have a lot of backstory. So in an ideal world, every medicine in the world would have been tested and FDA approved for children. Unfortunately, that's not how the FDA process works. In order to get an FDA indication for a medicine, someone has to ask the FDA for it. So this usually happens from pharmaceutical companies with a brand name or expensive medication trying to get an indication for something. So they have to request that the FDA review their report. They've put in lots of research dollars to try to get a medication approved in the hope that they can sell a medication down the road. If no one submits a report, or it's an old generic medication, it may never have had an FDA indication because no one was driving that financially. So in an ideal world, FDA approval makes it easier and nice, but you only need 2 studies to get an FDA approval of medicines if all the safety indications are there. So when we talk about things off-label, it simply means that it doesn't have FDA approval. It does not mean that there's not evidence base, and this is really important. I'm going to give you an example with anxiety medications in kids because I think it really highlights some of this. So in 2014, we got our first FDA-approved medication for pediatric anxiety disorders, or pediatric generalized anxiety disorders. That was for duloxetine or Cymbalta. Prior to that, there had been no technical FDA-approved medication for generalized anxiety disorder in pediatric patients. But when you go back through all the data and all the studies that's been done in pediatric anxiety disorders, there's actually many more studies for the SSRIs, and Zoloft has far more studies done with it than Cymbalta. Yet Zoloft was often done off-label and never went after an FDA indication despite positive studies. So sometimes the FDA-approved medicines are not the ones that have the best evidence base, and that can be really confusing for people too. It's also hard to get medicine approvals for off-label usage, sometimes through rational drug therapy. So You sometimes have to send, or I sometimes have to send actual articles to them about the success of off-label treatments if they aren't aware of them. So this can be kind of confusing. Does anybody have any questions about that point? To me, I still think it's a very confusing thing. So I want to make sure that that makes a little bit of sense. Okay. I can't see the chat either, Caitlin, so if anything comes up, will you let me know? Okay. I think it's also important to sort of have reasonable expectations for medications. And sometimes I think the idea is perfection, and I always said perfection is the enemy of good for some people, because a good medicine response at best is probably 70 to 80%. Some medicine success rates are 30 to 40% with a 50% improvement average. This could still be incredibly important. If you take really disabling conditions like obsessive compulsive disorder, a 50% improvement may be life-changing. If you have somebody that spends 12 hours of their day engaging in really severe and isolating rituals or problematic behavior, reducing that down to 6 hours is huge. It really impacts quality of life and function. But the success rate of OCD treatments rarely gets above 50%. That's why the therapeutic piece and engaging the exposure response is often so important. Things like ADHD medicines and classic biologic ADHD have much higher response rates, closer to maybe 80 to 85% response. And so nothing is 100%, and it's important to kind of document well and remind people of that. I'm sure everyone has had some experience with that, but people sometimes don't remember how bad it was. I've had families come in talking about tantruming behaviors or aggressive behaviors, and they may be telling me that the child's having problems every single day, multiple times a day in all scenarios. Then there's a period of success, but the child has another response, and happened maybe the day before the appointment, and the parent comes in frustrated that behavior occurred. And sometimes you have to say, you know, I know that it's still happening. It's not gone, but I remember when I met you, it was happening all these times. Are we there? Are we still back to that? Are we still having improvement? And helping people kind of frame that sometimes. But I think you have to sort of set up the expectation for people that it's not going to be all better while still giving this message of hope and improvement. I think more importantly, in terms of symptom response, is to really address their functional abilities. You know, same thing with anxiety medicines. I might get you 50% better in terms of your panic attacks or your anxiety symptoms. The real success is going to be going back to school, going back to work, going back to the functional things that your anxiety was inhibiting you from before. This next one is really important. It's simple, but often it really is forgotten. If a medicine isn't working after the right dose at the right amount of time, make sure you stop it. I see so many kids on polypharmacy that again, it's hard to tell sometimes if the timing has worked out, but the parents will just be like, I'm not sure this medicine has ever worked. If a medicine really has had no clear benefit that you or the patient can really articulate, it's better to stop it and go back to the drawing board than start adding things. And some of this is just because we have very limited evidence base in kids for multiple medicines. There's a little comic strip up here if you can't see it that says, the patient is saying, doctor, the medicine makes me feel worse, not better. The doctor says, let's increase the dose, which I think sometimes happens. That may make sense if you aren't to the dose yet that you expect success. Some medicines do need slowly titrated. But if a patient's having a lot of side effects, it's going to come across as not listening. And so you really either have to provide psychoeducation or decide to go a different direction. And number 8 is monotherapy is better than polypharmacy, which again is something that's similar to the last one, but I will tell you the most common thing that I often see is, and it makes me look, I guess, smarter than I really am, but I get a lot of referrals where pediatricians started something. It was totally the right choice. It was totally the right medicine, but they never got to a high enough dose or the right dose to have success. And so sometimes they started adding something instead of just increasing the dose. It's always better to make sure you have fully explored the full capacity of one medication's dose than to add an augmenter, unless there's really good reason to add that augmenter. And sometimes there is, but it really is important. And again, because especially younger kids under 12 brains are so poorly developed, we just have very limited information about how multiple medicines with multiple sort of neurotransmitter pathways or activations sort of can impact that. And kids will end up with much higher burdens of side effects from polypharmacy than using just one medication too. Number 9 sort of parallels that. It's always important to start low and go slow, but prescriber anxiety can sometimes get in the way of giving people an effective trial of medicines or knowing what an effective trial is. I see this a lot with stimulants. You know, people sort of in their minds sometimes have doses they don't want to go above, even if it's still within the FDA approved range of that medication. And so it's important to sort of know the medicine and what the range is and not forget to increase it. We've had several cases the last couple of weeks in ECHO where we've talked about like SSRIs for OCD or sort of obsessive anxiety. There's a lot of evidence that those higher doses of SSRIs are maybe much better for that type of anxiety other than lower doses. And so I look really smart when I just increase the doses of things, even though I'm still well within that range. I see that with stimulants too. The stimulant isn't working for ADHD. The pediatric patient's having 0 side effects. The vital signs are normal. You would just increase the dose. And so I think sometimes it's important. And sometimes it's not the prescriber's anxiety. Sometimes it's the parent's anxiety. And so I have this phrase I've been saying a lot, and it really helps me not get stressed either. If you expose a patient to a medicine that's not working at the wrong dose, you are exposing them to all of the risks of the medication, but none of the benefits. And so I think that really helps me sometimes think about that is if they're not getting benefit or I'm not at the right dose, I'm actually not giving them any of that benefit in that risk benefit discussion of this medicine, but I'm still exposing them to the risk. So I think that's a helpful way for me to kind of balance that, because lots of times the discussion we're having with patients is sort of this risk benefit. You've obviously chosen to start a medicine because there was some functional problem that was getting in their way, and now we really want to try to be helpful to that. We made the decision to try medicine because other things weren't working, or we just thought that was the right thing. We need to keep going with it to make sure that we're successful. This is also a really important question too. As I said, I get that the idea of having to put your child on any medication is really difficult for a parent. I think it's hard, and a lot of people worry about that, especially psychotropics carrying kind of a lot of stigma and lots of questions, but there are significant risks to not treating things too. And as we expand our discussion about risks and benefits, we really have to say to people, well, what are the risks if you don't treat with medication? You know, that's a challenge, thinking about like depression and anxiety. Especially depression, like the risk of not treating a severe depression with medication may be suicide, especially in a patient with recurrent self-injuries or attempts. There may be really high risk to not treat if other things aren't working. I have to have that discussion with people with ADHD too. What are the consequences of untreated ADHD? It's totally your choice as a parent to choose to treat it or not, but there's some real risk to untreated ADHD. There's definitely higher risk of substance abuse. There's lower performance and graduation risk from school. There's higher incidences with driving because you can't pay attention. There's higher risk of depression and anxiety from self-esteem issues related to sort of self-efficacy issues with not feeling like you can control yourself. So there are certainly considerations, and when you have these risk-benefit discussions, it's really important that we ask that. And I live in the land of risk-benefit a lot. I find it a really helpful place to be, and I think it can be an individual choice for the family too. It's not the same for everyone. This is the same place that you live with pregnant patients too. You know, what are the risks and benefits of treating during pregnancy? Huge questions. And that benefit for some person may be very different than the benefit from another person. And people's sort of personal considerations need to kind of be weighted too. But I think if you live in the land of risk and benefit and you have those deep, meaningful conversations with your patients, you'll always kind of make the right decision for them and for you. But you do have to ask, what's the risk of not using it? Number 11 is kind of interesting. I believe medication should be a choice for kids. This doesn't always settle well with parents, but I really think kids need to understand why they're taking a medicine and why. Otherwise, I think it really sets up this power dynamic that's really uncomfortable and not great for kids and parents long term. You know, ultimately, if you're holding your 4-year-old down to give them an antibiotic for a week because it's life-threatening and they just need it, that's a lot easier decision to make because it's time limited. But when we're talking about psychotropics, you know, you got to have some buy-in, especially with things like ADHD. You don't want there to be a fight over taking the medication, and the child should have some benefit, some appreciation that they're having benefit too. I tell you, I kid you not, but at least a couple times a month, I have parents with kids in my office talking about holding down their teenagers and wanting to force medicine on them. And it's just such an unhealthy family dynamic to be in, that it's just not the right way to approach what might be a longer term medication. So again, you don't have to make it complicated, but you know, I think kids are smarter than we give them credit for sometimes, and sometimes actually the kids are the ones saying they want the medicine. That happens too. I have parents that sometimes struggle with that guilt about giving their kids a medicine, and especially around ADHD medicines, and the kid will say, oh my gosh, my life is so much better. I'm doing so much better. I feel so much better when I'm on the medicine. And if you can foster those conversations, it helps the parent too. But I like to use the kids' words about what they think. Sometimes it's things simple like, this medicine just helps me be good, or sit still. This medicine makes me happy. And I'm just trying to, again, understand it from their choice, because as they get older, they're going to have to make those decisions for themselves. And this is especially important in teenagers with their own identity and autonomy sort of burgeoning. If they're not going to do it, it's better to just not offer to prescribe it and just follow them than to get in a situation where they're taking it some days and taking it not, because those types of patterns also lead to that question you have. If you just take an antidepressant twice a week, you're going to get all the risks and none of the benefits. And so it's really important to kind of understand what's getting in the way. And so I never force anyone to do medicines. I'll even follow people that adamantly do not want to do ADHD meds or something like that. And I'll keep seeing them. I'll keep checking in on them. We'll see if they're trying other things. But as I said, it really is important that they feel like they're part of the decision. Principle 12 is that side effect monitoring is ongoing. Sometimes most side effects are most likely going to show up in the initiation and the tapering phase, but they really can show up at any point. And so, you know, one of the reasons you keep seeing people back is to make sure the diagnosis hasn't changed, but also to make sure they haven't developed a side effect to something. Weight loss is huge with kids, or weight changes. I have had kids that, for whatever reason, may have gone 6 months without an appointment, even though we ideally try to see our patients for ADHD at a minimum every 3 months to check weight. But I've had kids lose like 15 pounds, which is a lot for a little person to lose. And you have to kind of be mindful of how quickly things can change in pediatrics, sometimes more so than adults. Number 13 is that the diagnosis can change too. And I think that is so important. I think it's important that we make notes, that we remove the diagnosis. Simple things like if a patient has depression and they suddenly show up with a manic episode, they no longer have depression, they have bipolar disorder, and it's really important we change our diagnosis and change that. I'll have kids that come with horrible oppositional defiant disorder. Really, they have ADHD, and the moment their ADHD is treated, those oppositional symptoms disappear, and so that wasn't really accurate. It was really untreated ADHD, and we need to make sure that we do that. Kids can disclose trauma or have traumatic events at any point. This can really change their presentation. So it's important. This is a real pet peeve of mine. I see kids that have had lots of psychological evaluations, like if they're in placement, and they have sometimes laundry lists of diagnoses, and or they'll carry forward historical things, and it's really important that we make sure that those are still accurate, and to try to make sure that we didn't miss something. I've had kids disclose trauma that may have really explained the things that were going on, and it just never got updated. And so it's really important that we maintain the best diagnosis we can at the time we're seeing someone. And then 14 is there's no miracle pill for sleep. It's such a critical symptom. It's back to one of those symptoms that we talked about. That's just such an important thing. Everybody needs sleep. Parents need sleep. Kids need sleep. But there just really are no miracle pills for sleep. We have medicine that helps sleep, and getting more sleep is better for everybody's mental health and makes many, many things better. And sometimes when you don't know where to start, I start with sleep. But truly good improvements in sleep require a lot of things. Medicine may be helpful, but it really helps to track sleep. It really helps working on sleep hygiene and a lot of other things that are really important. It really helps understanding what for that child and what family, what is the part of sleep that's most challenging. Sleep can be incredibly scary for some kids to go to sleep. And so when in doubt, start with sleep, but realize that medicine is only going to be a very small part of the solution, if at all. And then the fifth basic principle is to see people back often when they're kind of in crisis or with kids. Usually when I'm adjusting medicine, I'm thinking trying to bring them back within a month. One, to reassess side effects and make sure I keep going, because we are going sometimes slow with these medicines. I want to touch base, and you can change things quickly. You can change stimulants every week. You can change SSRIs every month in terms of the dose. And maybe you aren't seeing them in person, but you're asking for some touch-in. I don't have the ability to see all my people this often, but I frequently will do like check-ins by telephone, or we have a MyChart messaging system, and I'll ask them, I want you in 2 weeks to send me a message so I can quickly decide if we're going to keep going with that taper or to see if we need to change things. And this is a way to really kind of get control of a problem fast. It's also just, I think, especially with sort of mood disorders and suicidality, even though you may not feel like you're doing something, that human connection of checking back in with someone and knowing that you care and you're working on it, it's a place they can talk about, can be huge in terms of engagement, improving safety as part of things. So if you're not sure what to do sometimes, just say, let's check back in a couple of weeks and just really see where we are. Sometimes they cancel the appointment, and I say, if you cancel it and things are going fine, I'll assume they're going fine, you can cancel it, but I just want to have something for you where we can touch base in person. And that's sort of it for today. There's the PALS line number again on the screen. Just to remind you all, I was lucky enough to get a consultation line for child and adolescent psychiatry that any pediatric provider can use, and that number again is 304-694-7257. It's a phone I carry with me from 8 to 5 Monday through Friday, and I'd certainly be more than happy to talk you through any child case or provide some guidance in between our sessions. So, thank you guys. Does anybody have any questions?
Thank you, Lauren. That was wonderful. We really appreciate it. Everybody, you're welcome to unmute yourself, or you're welcome to chat in any questions or anything you need to talk about at this time.
I was just going to ask a quick question. I know you mentioned some stigma related to psychotropic prescribing. Have you personally experienced that with perhaps a parent feeling stigmatized that their child will receive some sort of medication? And if so, how would you go about that situation?
So yes, I actually see it a lot. I think if you see it, it's a really good sign actually, because they shared it with you. I think a lot of people have it and they don't talk about it. I have a lot of parents that just sort of fundamentally are against medication, and yet they know the medicine really helps their child, but they kind of have this, I don't think this is on the parents. I sort of approach it as sort of talking about society. Our society is not kind to parents. I think it's true that we are more willing to ask for like help to help our pets or do dog training than we are sometimes to admit we need help parenting a child. Or some parents feel like medication is kind of an easy out, or they have strong feelings that they should be able to parent better. So the biggest theme I would say that often comes out is the sense of guilt. And so I really try to do that by listening to the parent and what they're concerns about. I really focus on functioning and really talk about the things that were not functioning well. I usually am in parents that have really tried a lot of things. I spend a lot of time validating things that they already have done well. If you look at the science, there's not a lot that any one person can do to improve impulse control and attention. Those are fundamentally hardwired things that have been really linked to kind of dopamine access and regulation. But even these kids can't pay attention. They're not doing it to be bad. And sometimes that conversation with the parent is this disability perspective that there's so many things we're born with, there's so many things that we don't have choices about. But this is something that really medically exists, and I support this. There's you can't make your child pay attention just by willing them to. We can't do that. Sometimes it's a conversation about their beliefs about what a kid's capabilities are when they just aren't accurate. Most of the time it gets better as the kid gets better. I think when the parent sees the success the kid has, or the kid feels better, that makes it so much easier. But it's hard, and as I said, on the flip side, there are some parents that only want medicine. There's some parents that come super focused on medicine. But I do see a lot. This is a little bit stereotypical, and some of this has evidence, some of it is more just, I think that parents with higher socioeconomics have sometimes are more resistant to medication, the belief that they just need more services or more exposure sometimes. A lot of it sometimes is just some cultural stigma about psychiatric health in general, that it's not real, or this kind of you should pull yourself up by your bootstraps philosophy that should just snap out of it, that sometimes is. I see this more culturally in West Virginia, sometimes generationally. So again, a little bit sort of stereotypical, but we have a lot of grandparents parenting kids, and there's a lot of generational differences about mental health treatment. Younger generations, millennials, are much more open to the idea that mental health can be treated, much more likely to view it as biologic, where older generations still sometimes put a lot of belief on sort of more the social or the parenting aspects of mental health. And so spend a lot of time like talking about the biology of what we know and what we don't know, because there's components, and the answer is mostly that they all kind of work together. So even if you have really stressful environmental things, they may be worsening the biological presentation of things too that still might benefit from medicine. I hope that answers your question, but those are hard discussions. I think the biggest thing is you have to kind of sometimes set aside some time to have those discussions, which is hard to do in busy clinics. The way I've been able to do that, and if you haven't ever tried this, it's helpful. You can build time for E&M codes, there's a way you can actually build time. You can build kind of high-level E&M 4s and E&M 5s by time alone. So I sometimes will plan on extra time where I can do a quick note because it's based on time and not the symptoms.
Thank you.
Thank you. Lauren, we had a question come in via the chat. I'm going to read it real quick. So they said thank you. So we've had several people say thank you. But I was wondering if the question is, I was wondering, do you often obtain input from teachers regarding the presence of side effects? If so, do you find that they often yield valuable information that parents may not be aware of? Are there any measures that you would recommend for monitoring the side effects? And I know follow-ups have Vanderbilt's have modified version of the Pittsburgh side effect rating scale embedded, but is there anything else that you'd recommend a teacher complete to monitor side effects for other classes of medications?
So I'm going to answer this a couple different ways. I tend to use a little different rating scale. The Vanderbilt is very good. I actually don't ask the teachers directly about side effects, but what I do is I have some short forms for ADHD, like some quick checklists that I will write usually a personal note to the teacher on the bottom. Is there anything else that you want me to know or anything you're seeing? I sometimes write questions about timing. Are there any timing differences? So I'll write kind of little notes to the teacher, and then they can kind of freely respond. And I think they appreciate that because I value their time in figuring out the rating scale, and it gives them kind of this free flow to write. I've had teachers write me huge letters. I think if they know I care, they can put a lot of things. And I've had teachers tell me this kid looks like a zombie, or I've had teachers kind of comment on that they sleep a lot in class. So that's probably how I've done it mostly with the ADHD rating scales. I try to send, if a parent is really complaining about major changes in behavior, I try to send more of a broad-based scale. They cost money and are not free, so I'm aware of that. I have sort of made some ones that are sort of off-label, like that I pulled, but there's some child behavioral checklists, and some of the school psychologists will give the teachers the BASCs, which is, I'm sorry, I forget it, something scale for children, behavioral assessment for children, I think, where it's a standardized thing. And what I find is that sometimes the problem is not the ADHD coming back, there's something else going on. And so often I'll send those broader band rating scales that look at ADHD, that look at anxiety, that look at other behaviors, and I'll get all this information about something else. Like the kid may be having trouble at school, but everybody seems to think the ADHD medicine is fine, but why is he doing poorly at school? And I'll send this broader based rating scale. And what the teacher will send back looks a lot more like depression or anxiety, or I'm screening for other things. So I try to do that once a year, especially, or when something kind of comes up. Honestly, I have never not had a teacher excited to call or speak with me either. So I sometimes will get a verbal release and call. People are so excited, like, if they don't want to talk to me, I know it's probably fine, because I have had teachers pause an entire class to get off the phone to go talk to me because they knew what they needed to tell me something important. So when I'm really stuck with what's going on at school, that verbal contact really helps. But that little short note I seem to write at the bottom, please let me know if you have any other concerns or see anything, has really been helpful to me. I haven't tried the side effects per se. I'm pretty anal, and I go through with all the patients the side effects and kind of try to ask them, or there's some side effect rating scales I'll use in my office, but I think it's would be helpful. I haven't tried it. Has anybody tried side effects from a teacher before? That's kind of cool. I hadn't thought about that.
That is interesting. We should definitely talk about it when we have a lot of school-based health providers on. I know we have them sometimes. Well, thank you again, everybody. If you have any further questions, you're welcome to email us, and we'll make sure that Lauren gets those. Lauren, I know that in the future, I don't have dates in front of me right now, but in the future, you'll be doing more presentations for us, kind of built off of this. Do you care to say, I know like anxiety or ADHD, is there anything else that this might be applicable for?
So what I can do, and maybe the group can tell me what they'd like to hear first, I have sort of various psychotropic prescribing talks and sort of the different classes. So I have a whole talk on ADHD medicine and ADHD. I have a whole talk on pediatric anxiety disorders, depressive disorders, like antipsychotic medication. I can break it down a lot of different ways. All these principles kind of apply to all those things, but we can kind of get in the nitty gritty with certain diagnoses. So I can start with whatever one the group wants. They're already done. So I just have to.
All right. So everybody out there, you heard it. Let us know what you want to hear. We'll get it planned out. If you do have any cases or questions that you think will be really cool to talk about in this structure, you know, obviously we can plan for it. You don't have to submit it and present the next date. So just let us know. And then we have about 10 minutes left, everybody. I just wanted to ask how everybody's doing and see if everybody's doing okay. I know things have been super weird. I know it's probably not safe, or it's probably safe to say that everybody's been stressed out in a different way. So is there anything we can do for you? Is there any questions you have? Are there any interesting things going on? I will say, so Project Echo is holding COVID Echo sessions now as of tomorrow. Every Thursday in April, we will be taking the lunch hour to discuss the situation. We have some infectious disease personnel going to be on the call. I think we're going to have a governmental person talking about some of the rules in place. You guys are welcome to email or submit questions, and we will get them addressed. You can always watch the YouTube video afterward if you're not able to attend. But just so everybody's aware that that is going to be out there. It's been fun to get it together in 3 days or less. All right, everybody. Lauren, thank you so much again. Thank you, everybody, for coming. We'll see you guys again in a couple weeks. Dr. Goody Kuntz is going to be here. I need to confirm with her, but she is supposed to be here talking about countering misinformation. So if like patients come in with a very strict idea that therapy doesn't help, how do you talk to them about that, etc. So if you guys have questions about that, just let us know. We'll see you later.
Thanks, guys.